Hello, everyone. Glad to see you all made it for today's call. We're just going to give just another minute just to get more people situated and admitted into the Zoom room. Hang tight.
Hi, Alana.
Hello, how are you doing?
I'm fine. You can hear me?
Yep, I sure can.
Well, that's excellent. There you are.
Here I am. Adjust my screen here.
Hi, Zorba. Just saying hello to one of my dogs.
Well, I apologize to everybody if you hear my dog barking in the background. He's usually my office manager, but he's kicked out today.
Oh.
It's kind of noisy during calls.
It's good. It's good.
Yeah. So, all right. Well, again, welcome everybody.
Oh my goodness, we have 27 people on. Okay.
Yeah. Yep. Hopefully we'll get a few more people joining in. Again, welcome to today's Regional Quarterly Community Coalition member call. I'm just going to check. Good morning, Glynis. Yep, if you want to just type your name and your coalition name into chat, that'd be awesome. So with that, let's get going. Just a few logistics. If you want to just make sure you're muted during the presentation, but for sure, if you have a question, we'll keep it casual again. Just take yourself off mute. Also, if you have any questions, comments, want to share a story, anything like that, just go ahead and put that right into the chat box. We definitely want to hear your experience, so please share it with everybody. That's the whole point of these calls. So we just want to, sharing is caring. So today we're going to do some welcome introductions. We have a couple new Mountain Pacific staff, and we also have a few updates, and then our CMS task order director, Mary Erickson, will give a couple CMS updates and how it affects coalitions. Also some upcoming events that we have on our Mountain Pacific website and a few other events that we want to share with you. Also, we will have Dominic Fitzsimmons, our new analytics team supervisor, go through a data dashboard for community coalitions. And then myself and Mark Marabella, we will be talking about age-friendly health systems. And then Dr. Catherine Borganich, she's going to be talking through the application and just kind of run down with age-friendly health systems. She's got a lot of experience with it. And then we'll finish off with questions. So that will get going. So just wanted to introduce Mary Erickson. She is our task order director. She's going to speak about CMS and how it affects Community Coalition, just the updates that we have for you. Also, Caitlin Conway, also from Mountain Pacific. She's going to talk about some vaccine work with Mountain Pacific. And then Jill Holt from the nursing home side. And then also, Mary, if you want to just talk about our Mountain Pacific new location. So with that, I'll turn it over to you, Mary.
All right, sounds good. Thanks, Alana. Welcome, everybody. I think I'll just take the easy topic first, our new location, our headquarters. For those of you that may not know, we are headquartered in Helena, Montana, and we've been located at 3404 Cooney Drive for a long, long time. And it's an old hospital, and we decided to upgrade that location, and we moved just to a place that's in downtown Helena. We also were able to downsize our footprint quite a bit. Our staff has gone to a lot of remote work, almost entirely remotely, for some of the QIO work that you are all participating in. So with that, we're able to downsize and save some expense. So that's been nice. I believe the new address in Helena is 500 Park Avenue. So let me know if you need any more information. Anybody who was financially involved with us should have been notified already. So, so hopefully let me know, I guess, if you haven't been notified or if you have any questions on that. The next thing, updates from CMS. So we've been talking for a while now about a modification that they have been working on that's been underway, and understandably so, with changes in Health and Human Service Administration and things like that. It's taken some time to get together a final request for proposals. So about 2 weeks ago, we had a meeting with CMS, and they gave us a preview of some of the things that are to come. And I just wanted to give you all a heads up, from those of you that are doing work with the coalitions, that they intend to expand our work into rural and disparate communities. So there's some redefining of our target populations going on there. It's not going to affect any existing coalitions that are already up and going, so don't worry about that. It's really just more which populations we're affecting, and making sure that we're getting better coverage of and more health equity, with a big focus on health equity for our coalition work going forward. So that's coming down the pike. They also are really encouraging and wanting us to include more non-clinical entities in the coalition work, which a lot of you are already doing. But that would mean things like including churches, faith-based organizations, law enforcement, wherever it's applicable, to start including some of them, those other entities in our work. So trying to go beyond provider and hospital type coalitions. So that will be good. I think is a good change, and it's good to have them included. And like I said, a lot of you are already doing that. So I don't anticipate that being a big change for the coalitions that we have going. And then the last thing that I wanted to mention, that they are going to have us expand our work into emergency preparedness, especially in nursing homes. And so we are actively kind of looking and watching for experts in that area that may be able to help us out, and just help the nursing homes with that final kind of emergency preparedness, evaluation of their response, how to put in any other mitigating factors that maybe they need to, looking back at the pandemic. So those are some of the high level things that are probably going to affect, and that you'll start hearing about coming out through our coalition work. Any questions on that? I'm happy to take questions, concerns, anything along those lines.
I don't see any questions yet.
Okay.
And feel free to just go ahead and take yourself off mute if you wanted to ask Mary anything regarding the updates she just gave.
Yeah, this is Catherine Borganick, and again, I'm still sort of confused about this emergency stuff, because the nursing homes have to have an emergency plan. So what our piece in that is really sort of just checking with the nursing homes and saying, hey, what's your emergency plan?
I think, and this will be, I'm not entirely sure how much of that will come through the coalition work. I'm really kind of just putting that out to see if there are resources out there that have done nursing home emergency planning and could be a resource. This is really, I think, more activity that's going to take place on our nursing home side of the house and with that specific task order. And that will be essentially where our account managers will be helping the nursing homes evaluate their plans, how well did they work, what kinds of things need to be put in place, those kinds of things. But good question.
Perfect. Well, I don't see any more chat in there. Those of you who came on just a little bit ago, go ahead and put your name and which coalition you belong to in the chat box. I'm going to move over to the new Mountain Pacific Quality Health staff. Jessica, I think I have your last name wrong, but you can go ahead and unmute yourself and just introduce yourself.
Hi, kind of correct. Jessica Lystra, new last name is Fry, so I'm trying to remember to put my actual last name on things. So Jessica Lystra, I'm up here in Anchorage, and we are working on the Care Transitions Coalition.
Awesome. Thank you. And then Dominic?
Hey everybody, happy Tuesday. Thanks for letting me join in. This is the second coalitions meeting I've been able to crash, so I'm having a great time. But I've been around for about 2 months with Mountain Pacific now with the analytics team, and my background is a lot in state public health and more recently higher ed. So my focus with being involved with the group is to provide useful and meaningful tools to help access and understand data. So I'll have a little time for some demo later on in this meeting today. So hopefully we'll find some things that are looking good to the group.
Awesome. Thank you. Is there anybody else? I'm just kind of scrolling through my participant list.
Yeah, hi, there's one
Oh, go
more
ahead.
here. I'm Ray Tupling. I'm another member of the analytics team at Mountain Pacific. This is actually my second day with Mountain Pacific, so there's a steep learning curve ahead of me, but I'm sure it'll be fun. Look forward to getting to know everyone, and nice to meet you.
Awesome. Thank you. I'm just still scrolling through there. So if you're a new Mountain Pacific employee, go ahead and take yourself off mute. I'm really trying to look through there. I know we've got quite a few coming on, so happy to hear, happy to have new people on Mountain Pacific. Pretty awesome team we have. All right, so some upcoming events. Caitlin, I'm gonna let you talk about the VaxFax open office hours.
Yep, thanks, Alana. I just wanted to, good afternoon, good morning, wherever you're at. It's great to see everybody today. So in addition to some of the work that Mary was talking about, CMS has also asked us to take an effort in working on improving vaccination rates for COVID-19, of course, and then along with pneumococcal and influenza. So we're seeing in our region that our rates are definitely a little lower than we'd like them to be. The pneumo rates are usually between 20 and 30% for our eligible beneficiaries, and influenza is right around that 30%. Our nursing homes are doing a lot higher. They're more in that 80% or so. So hopefully we can spread some of the best practices we hear there. So our hope is to work with our community coalitions and our nursing homes to increase those over the next few months and year, I guess, as well. So as an effort to do that, one of the things that we're working on is a VaxFax open office hours. And we will make sure we drop that link in chat. It starts tomorrow afternoon. And so through that, you'll have access to our pharmacist, our chief medical officer. It's going to be very open, where you can have questions, answers, sharing, and then we'll be focusing things like, how do we make a strong vaccine recommendation, vaccine hesitancy, vaccine efficacy, and sharing a lot of the stats that we're seeing in our area. So we'll be able to kind of pull up what's happening in your communities, share that with you, and then provide tools, resources, and anything else you may need to assist with those different areas. I don't know if it's on here. Oh, we'll get to it down, but the Project First Line kind of goes hand in hand with this as well. So they're working on infection prevention. And so we are partnering with that team to include some vaccination updates there. And so more to come on that when Crystal shares. So thanks, and make sure you join us tomorrow. Great opportunity.
Perfect. And I just realized I totally skipped over you, Jill, for updates on nursing home. Caitlin kind of gave a little rundown with the vaccinations. So Jill, if you want to speak up about nursing home updates.
Thank you. We, as Caitlin just mentioned, we are also in the throes of improving vaccination rates for nursing home residents, and those same vaccination emphasis on COVID, on pneumococcal, and then when flu season gets here, we'll be focusing on influenza uptake vaccinations. And then in addition to that, we're just trying to help navigate something that's concerning to, I think, all of us who have loved ones in a nursing home, and that is this visitation. Just even today, there was a new release from CMS regarding visitation guidelines. So we're just really trying to stand in that gap and be supportive of nursing homes and helping them to develop policies and procedures for when folks come and go from the facility, when they go home to visit, or when they have visitors come in. So that's really been kind of our heavy lift for the nursing home team.
Perfect. Thank you, Jill. And then Amber, are you on? I believe you are. Going to the 3D echo update.
Welcome, everybody. For those of you that have not signed up, it's not too late. I can put the invitation in the chat box when I get done speaking, but we have started a echo series around substance use disorder. And so we've had 2 great sessions so far, and we have 8 left in this series, and then we'll move over to dementia for the next session. So for those of you that aren't aware, an echo session is a short didactic presentation with our experts that we've contracted with. And then we review a case review form, and then we allow our experts time to weigh in and give some advice around the case. So our 2 sessions we've had so far have been very interactive and super helpful. So you're all welcome to join us.
Awesome. And I echo that. It was very, very good. The session that I attended. It's very good. And then Mark, I'm going to speak to the Aloha Kidney.
Absolutely. We had a conversation this morning with Dr. Ramona Wong, who runs the Aloha Kidney series itself. May 8th is the first class. The first live Q&A will be on May 15th, and the program will run through June 2021. It is a class that is anytime and anywhere, so it's recorded. When you actually sign up for the series, you will get a link, and that link is good through the end of May. And you can sign up, go through them at your own pace. Wherever you leave off, when you pick it up again, it will be in that same spot. All are pre-recorded, and all who enroll will automatically receive that a link each weekend for the next class. First class is 2 hours long, and the link will be available, as I said, through the end of May. And you can enroll online at alohakidney.com, or you can call 808-585-8404, and I'm going to put it in the chat for you right now, and it will also be in the notes. Okay?
Great. Thank you, Mark.
Yep. There we go.
And then Crystal, Project First Line.
Okay, hi guys. Yes, so Project First Line, again, we are trying to get our the most bang for our buck. So we are looking, or we have started an ECHO program, and for any of you that have gotten onto the ECHO programs, it is around infection. It's a comprehensive infection prevention and source control. And talking about each session is, of course, a learning series. And as Amber said, it's a didactic session as well. So the next one will be May the 6th, and we're focusing on something a little different. We're taking a break from more of the learning sessions, and we're going to switch our voice to the power of language during crisis. And so it's going to be really good and very interesting to see and learn just different ways to talk to each other and communicate better. And then the second thing is on, as Caitlin mentioned, the family and caregiver series around vaccination and infection prevention. So what we learned from the learning needs assessment that was sent out was our nursing homes and, a lot of our healthcare organizations were supported. They felt supported. They felt that they had some training under their belt, could use more. But something that came out of that was, can we support families and caregivers? And so that's how this collaboration became with AARP. So we're getting ready to kick that off next month. Again, we're going to button up the sessions and button up the timing. So look forward to more on that. Thank you, Alana. Yeah,
thank you. Great. Yeah, we've all had to pivot a little bit. I think that's a key word for the year that shall not be said. And I applaud everybody's efforts. And I know that it's really hard, struggling, trying to keep your coalitions together, trying to meet, trying to focus and what to focus on, even now when we're talking about post-COVID, when we're kind of still in COVID. So just know that we are here for you. We do listen. You know, looking back at our January meeting, we did a polling question with you guys to ask like what kind of useful tools, events, things like that. And so some of these are kind of spun off there because we do listen. So if you have feedback for us or recommendations, our ears are wide open. So with that, Dominic, I'm going to turn it over to you, and I assume you want me to stop sharing.
Yeah, please do. I will throw my screen up there too. So some of you, if you were on a previous call earlier in the month, you would have seen some of this information. Let me see if I can find my correct screen to show you. Trying to see if I can see my screen coming up here. I do not see it. I'm just gonna, sorry, just gonna close a couple of windows here. Okay. Now I think I got it. Hope I'm sharing the right one here. Yep, this looks correct. So what we've been working on, just for those of you that hadn't had kind of a preview of this, and I just want to kind of let you know first that what we put together is historical beneficiary-based data into an immunization admissions and readmissions dashboard. So this isn't exactly the most up-to-date information, but that's part of our plan going forward, is to replicate some pieces of this, of course, with your feedback and your input on exactly what you would like to see in a dashboard. And the main idea is to pull together useful information related to community coalition work and to expand upon some versions that we're making right now and to provide regular updates to the data. This is all done in Power BI. Some of you probably are fairly familiar with different types of dashboards, maybe in Tableau too, but for the time being, what we're going to be able to do is, once we've kind of arrived at a really good place where we're providing you the good information that's useful and helpful for your work, we'll be able to export that to you in some PDF and probably Excel formats until hopefully down the road we can get you access to a more live functional version. So future goal, but I think we're starting off in a good place where we're going to be able to get out some data to everybody. So I'll just run through here and give you a demo of how these work and the setup. Up at the top here, we have got these maps that have our immunization based on beneficiary info. Again, I'll just pick on Alaska here, but this is data for pneumococcal vaccination rates based on the beneficiary pop in each of these zip codes. And this is 2015 to 2020. So I'm sorry it's a little bit slow, but what you can do is you can slice through and hover over any of the geographic areas in our map. And when you click on it, and this is just a kind of a arbitrary goal that we popped in here for a vaccination rate, that of course would depend somewhat on your feedback and what you'd like to see. We really can put anything in there that's useful. So you can see here, when you click on a zip code, it will give you the rate, the overall rate in that 5-year period. And also, I'm sorry, it's really hard to see inside this. I wish I could zoom in, but there's a variance there between the vaccination goal and the rate, depending on where you click. So that works for all of these zip codes. And we also have some functionality in here too, where, for example, you could slide through here and just pull out the lower performers. And that will just pull on the map those immunization rates and those zip codes that fall under that particular range right there. And you can slide it around and pull out different subsets of information. So the plan too is also to link these up to our geographies that are based on your areas. And so you'll be able to have a personalized view, so to speak, when you're actually at this final product. And that's the type of report that we would like to share with you. So similarly over here for flu immunization, this is 2015 to 2020 data. And so I can pick on Montana here, and we have a couple of outlying zip codes that you can see there. But when you click on your area of interest, it gives you the 5-year seasonal flu rates for the zip code. So you can click around and pull all of this data. And what we're able to do is we can actually export all of this in the background really easily in a table. So end product kind of idea, just to get you thinking, was that if you're inside here at some point when you have access, that you can click on a little button at the top and export to a table. So you'll have your data, whatever associated data points. And you know, the great thing about this software is we can layer almost an unlimited amount of information on top of this. It comes from the ArcGIS program by Esri. So we can actually put on top this demographic info, population breakdowns. We can put social determinants of health. We can also put in drive time to healthcare facilities. So really it is, the limit is our imagination. And like I say, if you have any thoughts about it, I think it's probably okay for me to suggest you put them in the chat if you don't mind, Alana, unless maybe we'll blow up the Zoom, but that's okay too, or email me or any of us, I think. But it's work in progress, and we're really interested in hearing what you think. And I know for sometimes it can be a lot and you think, well, there's so much we can do, what do we do? But just try to think of an end goal and what you would like to relate any of your data to. So maybe that's a starting point. But I just have some more good examples in here to show the group. This is actually pulled in from the Hawaii Department of Health. They have a great COVID vaccine tracker on their website. And this comes in from a Tableau dashboard. So this actually comes in, it's embedded and it's live. So whenever they update it at Hawaii's Department of Health, this comes right in and it looks like it's refreshing right now. So you can see they have their doses administered and their tracking data is in here. They've also got a geographic breakdown, which is really nice. And the idea behind this is, and just FYI, we can do this with a lot of things that are out on the web. We can embed them inside our own dashboards. And so it might save some time. You know, if you typically go to the CDC or you're trying to source whatever out there, we might have the capability to embed it in a dashboard too. So that's something to think about. So this is really nice. They have their doses and their population coverage listed here. It has a breakdown by the different regions, which is really nice. They've also got age, race, ethnicity, and the different tabs. So there's a lot of fantastic stuff that you can pull in right here that can be relevant. So again, beneficiary info up here. And then we have state level information coming in here. Just as an example here, we typically are going to be including definitions, panels inside whatever product we put out for you. So you can always refer back and forth. And that'll be part of the navigation. So if you click on this information button here, it takes you down to the definition. So you can say, okay, that's not state data. That's coming from CMS. That's, you know, that's our beneficiary data right there. So this is an example of layering within Power BI. This is really cool. Kudos to CBSI for finding this for us. The CDC is putting out semi-regularly, I think it's twice a month now is their cadence, but this is estimated vaccine hesitancy. And it's for COVID vaccine. And there's also a combination of a social vulnerability index, and this is broken down by county. So I've incorporated their background raw data into our regions. So this is really neat. If you go zoom in here, you can click on any of the zip code areas in our region, and then that pulls in data over here. This drills through. So you actually have the percent of adults that were fully vaccinated at the end of last month. So we should get a mid-month update here pretty quick, and we can plug that in here. You've also got the estimated hesitancy. This is based on survey information. So in this particular zip code, 22% of adults reported being hesitant to receive COVID vaccine, 9% reported being strongly hesitant. And if I click back out here, you can see there is some variety. The color coding probably isn't very clear, but some of the areas, there's a lot of hesitancy going on. Look at that, that goes up to 27%. Wyoming has got some areas that's got some higher hesitancy going on, 32% there, some lower vaccination rates. So really fantastic data. In the background here, we also have some social vulnerability info. So this is just a sample of something that might be useful. I think as we're moving more towards integrating social determinants of health, and that's a whole world of data, but it can be so informative about even just a direction to move with coalition work. That is based on, in this map, 15 social factors, and that comes from the census. So I think there's housing, poverty levels, there's even lack of vehicle access is integrated in here. It's really kind of amazing. And I have it listed in here. It's kind of hard to see, but you can see, for example, in Fergus County, their social vulnerability index is 0.24. And I have a little slicer in here. And this is just an example of what we can do, where you can just pull those areas that have high vulnerability according to that vulnerability index. So you've got even some of the boroughs up in Alaska, they have a really high index, 0.73. Here's another one, 0.80. So you can imagine you could layer on a lot back there. You know, if you work with a particular population, it could even be our own data. You know, maybe people have a particular diagnosis or a need. We could pull that in here and we could scale it through and have that in the background. Really, if you can plug it in there, we can map it out and we can graph it out. So I think it's really exciting. Just a couple more things just to pad this out, to give you an idea of what we can do and what we're going to be working on your behalf. We also included admissions and readmissions data. So I thought this was pretty cool. Again, this is by zip code in our region. And I'm just going to go in here and see if I can select a good one. So for example, this zip code, when you click on it, the way I have this expressing is an admission reduction from baseline. So this is 2019 versus 2020. So this is how much the admissions were reduced as a percentage overall. And you can see it also parses out how the zip code was looking at each quarter of the year versus baseline. Some additional information, and this is kind of as an example too, but discharge information I think is always of interest. So for this particular zip code, we are also pulling in here the discharge disposition. So you can see the breakdown of where during that year beneficiaries were discharged to. So as an example, 61.3% were discharged to home or self-care. So all of the discharge destinations are listed in here. And you can click through and pull in the data for any zip code. It automatically updates. And of course, we have the potential here to integrate this with any background information that we probably could think of. You know, if we can compile it, I think we can do it. And similarly, this is for readmissions. So similar concept here. On the map, you select your zip code, and it will give you your percentage reduction. In other words, how well the area has done in reducing readmissions over that year, and it pulls in the related data. And you know, I think it bears saying too that I have a lot of maps here, but we can do graphs, we can do charts, we can do anything really. Maps are nice for visualization, but I think the plan too is to also have these link into time-lapse maps so that you can follow trends and have some really handy data. So hopefully that is food for thought, but that's where we are right now. We have a little bit of work to do with some of the data in the background on our side over the next week or two before it is really finalized. But I'm expecting that we'll be able to provide an initial report to coalitions within the next couple of weeks. We'll be working hard on that. So like I say, if you do have any feedback, we're really open to that. We would love to hear it. And it's kind of carte blanche at this stage, and it really is your tool to help us develop. So thanks for giving me some time today. Sure appreciate it.
Thank you, Dominic. I know we are very excited at Mount Pacific. Looks like Mary has a question for you in chat.
That would be Mary Schramke.
Yeah, Mary Schramke, sorry. There's too many Marys. Dominic, thank you for introducing us to some of these great tools. And I just posted a web link, and we can take this offline. It's some county by county data that comes from the University of Wisconsin. And I didn't know if, I mean, I was just introduced to this, and I didn't know if that was part of your data sources. But it's just, you know, one more tool. But like I said, we can take this offline. Thank you so much for helping us.
Yeah, and you know, I think there's value too. You know, there's a lot of data out there that ranks geographies by the social determinants of health, you know, very broadly. But I think there's also capacity and value for us as a group to reach a consensus on what we would like to see in as far as ranking and what are our social determinants of health. Of course, we have unique populations and unique needs. And so I'm really interested to get feedback related to that question too.
Thank you.
Perfect. So as Dominic went through some of that, and as some of us kind of have waxed and waned throughout our coalition work and trying to figure out what to focus our efforts on, we wanted to bring up the topic of age-friendly health systems. And I'm sure most of you have heard of age-friendly health systems, but if not, we're going to do a brief overview and just kind of talk through. And so Mark is just going to give just a brief introduction and what the actual goals are. And then Dr. Borgenich will be talking about her journey with age-friendly health systems. So Mark?
Yes, hello everyone. Our populations are aging rapidly, and they're going to continue to age rapidly for the next decade at least. And as we look through that, we're trying to figure out how can we provide the best care possible, and how can we create the least amount of harm, and how can we figure out what matters most to people who are aging, as well as people who will age into a healthcare system that would benefit from being age-friendly. Next slide.
I had Dr.
Oh,
Beast.
okay,
Yeah.
no, all right. No,
Sorry,
no,
Mark.
yep. No, I didn't take a look. That's my fault. Okay, well, let's go back to the other slide then.
Okay.
And the area that particularly that we're looking at is how we at Mountain Pacific could become cohort facilitators for different communities and different coalitions that are interested in adopting the 4 M's, which are what matters most to people, medications, mentation, and mobility. And we were on a call this morning with our geriatric workforce enhancement program, and we were looking at what we saw as a number of measures impacted over the third quarter in 2020. And one of the things that we came up with was probably mobility was one of the areas with very little visitation in nursing homes, and at the same time, people not wandering around because of worrying about spreading different disease or infection. So when we look at the 4 M's and what they're designed to do, they're designed to be worked as a set. And if you look at it from the standpoint, as I said, first of all, what matters most to people, provide you with a look at how to treat that person and provide a customized look at them. If you look at, let's say, from a medication standpoint and pain management, what do you want? The more pain management you have, the less contact with reality you have, the less ability you have to be balanced and strong and be able to move around. So might you be willing to look at other types of therapies that would enable you to be more engaged and also improve your mentation, your delirium, your dementia, or your depression, and work things through for you. And the other part that's really interesting from my standpoint is there's evidence base out there for these age-friendly health system that it can apply to all people within a health system, and is even more important to them as they begin to move into that aging population. They're more aware of the different types of surveys and the different types of testing that goes on to take a look at them as they age and the types of abilities they have, so that they are still actively involved in activities of daily living, and how we can treat them to make sure that they can stay as healthy and happy throughout their aging process. Did you have anything else, Alona?
No, we will kind of get to it towards the end, but I'm going to open it up to Dr. Borgenich, and I'm going to introduce her briefly, and then I'll just share my screen, Dr. B, then you can just tell me next. So Dr. Borgenich is a fellowship trained board certified geriatrician and is certified hospice medical director. She's also past director of palliative care consultants at Bozeman Health and medical director of hospice of Bozeman Health. She is currently a consultant in palliative medicine. She's been involved at the 4Ms and is currently working with an assisted living dementia unit to apply the 4M principles in that setting. So the floor is yours, Dr. B.
Okay. So there we go. So let's talk about really what the 4Ms are. First of all, it's a joint project of the Institute on Health Improvement and the Hartford Foundation. And I think the Catholic Charities are also involved in it. There are projects going on in 50 different states. Most of the projects center within a hospital setting or a primary care setting, but I think they're reaching out in various ways, and that's sort of what I want to talk about. This is a framework and not a prescription, and you need to fit it to your environment. And that's what I'm sort of working on with one of our places. The American Geriatric Society has added a fifth M, which is multiple comorbidities, which is before COVID was one of the, like the third most leading cause of death in this country. So I first heard about all of this about 3 years ago at an American Geriatric Society meeting, and was just sort of blown away by it because it's such common sense, wonderful things that we could all be doing within our various arenas. So I said before, the 4 M's are what matters, and I can talk a little bit more about that. That is not just advanced care planning. That is a piece of it. But really what we're talking about when we talk about what matters is what matters to the person is what is the matter with them. You got to think about that one for a minute. What matters to them is what is the matter with them. And so it's about their daily kind of functioning and what they need, what they want. There you go. This is this is it. What matters to you is what is the matter with you. And if you can keep repeating that and think about it in every aspect of this, it really reframes everything I would do as a practitioner and what I think we could be doing out in our other settings. Next slide. Okay, so the 4 M's are not healthy aging. We hear a lot about health in aging. And I've always had, as a geriatrician, have always had problems with that because we age. And so how do we adapt ourselves and our living to have health as we age, not healthy aging? It's not about the disease. So we tend to be very, very disease focused in this country. It's, do you have diabetes? Do you have hypertension? Do you have coronary artery disease, pulmonary disease? Everything is about the disease. And this is the 4M framework is not about the disease. It's much more person-centered and much more around what matters that day or in the next week, and is very person-centered. So when I talk about, for example, what matters, if somebody's having trouble driving, which many older people do, what are they driving for? It's not about the driving, it's where do they need to go? Do they need to go to church? Do they need to go to the store? Do they need to do whatever? Do they need to take a Sunday drive? That's what matters to them. And so then figuring out within that framework, if they're not safe to drive, how can we accomplish that? Next slide. Okay, so these are places, as I mentioned, where projects are being used. Primary care and hospitals, it's pretty well spelled out for primary care as to how they might approach it and what they could be doing better. And I can talk about that a little bit. Hospitals, in my setting in Bozeman, unfortunately, the hospital has not paid attention to this. I have tried, but there are a couple of other places, I think, in Billings that are looking at this. And I know Riverstone in Billings is using this as a model. Advanced care planning, and I'll go back to that in a minute, and then dementia unit. So I want to go back up to primary care because there's something. Yeah, go back. Sorry, I'll get to that slide in a minute. So let's talk about advanced care planning. So one of the projects that I'm working on here with one of the home health caregiving agencies is not only getting the document, whatever that may be, whether it's some kind of advanced directive, but also really drilling down on what the conversation is. And so we're looking at, do you have a document? If so, can we see it? When was the last time you reviewed it? Is it still pertinent? Does it need to be redone? And if so, how do you want to do it? There are some really great resources out there that can help patients and family look at this. One of the things I found out when I was in practice was that docs were very poor, or primary care providers, at actually looking at a document. It became a checklist. Do you have an advance directive? Yes. There was no further depth as to, did you do it 10 years ago? Do you know where it is? Is it in your safe deposit box where it shouldn't be? Do people know about it? Should we be re-looking at it because maybe your spouse died? So those are the kind of things that we really need to be looking at. And again, I'm working with a home health agency to see if I can help them get that piece going. Then I'm also working in one of the dementia units in town, an assisted living dementia unit. So and part of what we're doing there is really doing a good intake about what matters to them. What matters to them, maybe it's about their mobility, maybe it's about their advanced directives, maybe it's about what they eat for breakfast, or what they think, have they been gardening, are they farmers, or all those kind of things. What's their behavior and what are the triggers that we can look at around that? And then instead of just putting in a care plan in a folder somewhere, we're actually going to have a whiteboard in each patient's room, which will list things like family members and stuff like that, but also who is this person and what's most important to them? Is it music? Is it art? Is it gardening? Was it driving trucks, tractors, or whatever? And then what are their triggers that may trigger their behavior? And instead, again, in having it in a care plan, it's going to be right there in the room. So anybody who goes in there can look at it and say, oh, they're agitated today. Maybe if I try this, which is on the whiteboard, it will help them. So that's what we're looking on out in terms of the dementia units. Okay, now next slide. So when I look at this, these are the things that I feel I could have done better when I was in primary care, and what I hope to help people do within the coalition in various ways. I will say that I don't think you can take on everything at once, that you've really got to start small, and that's sort of what we're doing with each of these projects. So in a primary care setting, you can probably take on all 4 M's. In a hospital, you can take on 4 M's, but again, piece by piece, and then ultimately that it'll all come together. So what I could have done better is that what matters matter. And that I would always ask my patients when they came in, what could I do for you today? But I didn't frame it as what matters to you today that I can help you with. It's subtle, but it's really important. It changes it from what is the problem? And maybe they'll say, my diabetes is a problem. I can drill down on that a little further and say, what piece of it is really, are you having problems with? Is it that you can't, you hate testing your glucose 4 times a day, or you don't like this medicine, or whatever? It's not just about advanced care planning. And just a little, I hope I didn't write advanced care planning, because it's not advanced, it's just advanced. Just a little bugaboo that I have. Anyway, medication reconciliation. So when I was in practice, and I thought I did a better job of this, in order to do medication reconciliation, all we had to do in an electronic medical record was check a box, and then we have reconciled the medicines. That's not medicine. That's not medicine review or medication reconciliation. We really need to spend time looking at each medication. How are people taking them? Are they taking them? And do they know what they're taking them for? And how does it make them feel? It's a whole different thing than just checking a box. Evaluating and treating mentation problems, all 3, dementia, delirium, and depression, are all underdiagnosed in the older population and undertreated. And so people may say, well, there really is no treatment for dementia. And they're right on in one way, but there is a way of helping educate the family and indeed the patient about what they might, and also how to function within their current situation. So there's a lot more we can be doing around that. And then we need to do much better with hospital stays. And what we're interested in and what we've talked about is transitions of care. People in the last year of life may have as many as 4 or 5 transitions. And really, are we following that and keeping everything together? And I can tell you that we're probably not. And hospital stays, I think somebody mentioned it before, particularly with COVID, have really increased the amount of delirium and loss of functional status. There's some great stuff that's out there about hospital stays and mobility. There's this geriatrician, Sharon Inouye, who does this amazing study where she used a whole bunch of volunteers. Of course, with COVID, it's different. But I think even within the COVID framework, when people are in the hospital, there are probably things that we could be doing differently. We just need to pay attention and look at it. This is not something, unfortunately, and since I'm a doctor, I can say this is not something that docs really look at. They look at what are the medications I can get this person so that maybe I can get them out of the hospital. They don't look at things like, how do I keep them mobile so we can get them out of the hospital? Or what is their mental status so that I can get them out of the hospital? Next slide, if there is one. Okay, so here are some, I've talked about this a little bit. It's about the conversation, not the document. We need to educate our patients and residents and let them educate the providers, let them go to the providers and really, we know that if clients and patients are much more likely to ask doctors, and doctors are to ask them about advanced care planning. So as a coalition, I think there's a real big place in our community where we could do some education to the community. There's been some work done in churches. I think probably I've done some talks in libraries. I'm not sure how successful that is. I think you need to be a little bit more on a one-on-one basis or one in a small group. The documents and the things that I like the most is something, prepare for your care, which if as a coalition members, you should get on it and look at it. It tells you not only how to prepare for doing an advanced directive, but what an advanced directive might look like. And then the other resource I really like is a conversation project, similar kind of things. That's out of they're both out of California, actually. Next slide. So I talked about this, using the family, working with the dementia unit, drill it down on what matters. Next slide. Okay. So consider a venue, and that's what we're sort of doing and trying to do in Bozeman. Is I've got 2 different places that I'm working with now. One is a home health care agency, and one is an assisted living place. So consider what venue really wants to work on this, really wants to be engaged, and then do a little education with them. I've done a lot of that lately. And then consider 1M at a time. When I was there, there's a project in San Francisco through the hospital there, through UC San Francisco, where they're trying to get their electronic medical record so it is appropriate for the 4Ms. And it took them 3 years they first had to go through their EHR and see what was working and see what wasn't. And then they had to go back and sort of redesign it all. So it takes time. I've been now working on trying to get this going for 6 months in the assisted living, and I've just started with the advanced care planning. So just be aware, don't get frustrated. Is that it, Ilana?
Yep.
Okay.
That's it. Well, thank you. I know it's been a pleasure working with Dr. B, and she's been teaching me a lot around age-friendly health systems. And I think one of the things that I learned when we've been working with our coalitions, we've done work in Montana and Wyoming, and just getting the stakeholders together. For instance, Montana has a statewide work group called Age-Friendly Communities. So, you know, just kind of breaking down those confusions, like it's, you know, age-friendly health systems is this, and then there's age-friendly communities. So getting people at the table, GWEP, AARP, just all these different people that have started looking at age-friendly health systems and trying to collaborate and figure out where we can all partner and where are the gaps so we can help fill those in. Go ahead.
Oh, Alana, can I just say, this is just picking on a couple of things in this slide, which is when it says medications, I am less interested as a provider about increasing medication adherence as I am as to what are the medications really necessary. And that's, you know, we know that multiple meds is a big problem in the elderly. And then mobility, if I start talking to my patients about exercise, it gets me nowhere. I have eye rolling left and right. What does matter is if I base their mobility on what are their functional needs, what do they want to accomplish functionally. So I just think there's ways of putting things that make a little difference. So.
Yep, good point. And maybe you can help me answer this question. Agnes asked, healthy aging versus health in aging.
What's the difference?
Yep.
So to me, health, honey, I'm on I'll come find you. To me, healthy aging is, the emphasis is on, we want to be healthy for as long as we can. Great goal, but the reality is that we age. And I think it's not acknowledging age, and I think it's actually a little ageist to think, well, if you just, you know, as 90 years old, you want to be running a marathon. I think that's great. If that's what you want to do, great. But it's also not the reality for many, many people. So to me, healthy aging is different, because healthy aging assumes that we really don't age, that you can just continue to be healthy. But health in aging means that, okay, I am now 75 and I have some arthritis. I'm going to learn how to function with that arthritis, as opposed to that arthritis is going to make me not function. I think it's acknowledging that we do age, which is something that I think our country has a problem with. You know, we're very geared towards the younger person, and this is more valuing aging.
Yep.
Does that help?
Let's see.
Yes, thank you very much. That was great.
Thank you. And if anybody wants more information, or you want to know more about age-friendly health systems, or you want to get involved, go ahead and get a hold of Mark or myself. I will put my email, my email and Mark's email in the chat, or unless you want to do that, Mark. And this is just a polling question, just because right now we have these calls set up quarterly. So we just want to get your feedback if these continue to be helpful as a quarterly call, or if you would like to switch them to just having twice a year. So go ahead and take that poll there. Got about 15, about half the people responded. So go ahead, even Mountain Pacific staff, go ahead and put your response in there. And Mary Schramke had a question. Do you have guidelines for doctors and patients working together for medication, deprescribing medication?
Yeah. There's a lot of stuff out there. I sent back a thing to Mary. That could take a whole session, and I'd be happy to do that. But Mary, you could also call me or email me, and I'll get back to you.
All right. Oh, Mark just put it in there. Perfect. All right. Well, it looks like we are just about at the top of the hour. So it looks like most people are feeling like quarterly is still helpful. So good to know. All right. Well, I sure do appreciate everybody taking time out of their busy schedules today. We appreciate everything you are doing. And again, if there's anything that we can help you, whether it's data, understanding more, looking for resources, please don't hesitate to reach out to us. So again, the next call will be forthcoming for that information. All right, thank you, everybody. You all have a great rest of your day, rest of your evening, rest of your morning, wherever you are.
Thanks, everybody. Keep up the great work.